First of all, thank you very much for having a good presence in this session. So this is the first time Hitcon has taken initiative to have a master class, and as Mr. Vikram has told that Tele ICU and telecritical is a very sensitive issues, and believe me that we have gone through so many literature that it is definitely much life-saving. It reduces the hospital stay, it reduces the cost, and it is I think it's a very, very beneficial tool for all of us. So we should put some thought into this. As a critical care specialist, I started this Tele ICU concept last year, and we have one center in Mehsana that we already started since last 9 months, and we learn a lot of things. So I put some basic mechanism and what are the challenges of developing this Tele ICU, because this is a road which is really less traveled. So why I am telling that this is a very, very important aspects of a critical care practice in India especially, because we are at the moment still lacking the standards, laws and regulation. We have so many ICUs in the periphery which are lacking the basic trained staff. Forget about the intensivist. We don't have a structural training and formal certification for physicians and nursing. We are discussing about the critical care nursing since long, but it is very, very difficult to put into the practice. So we all know that the training of nurses and training of even doctors, they are not up to the mark. ICU care, if you look at the rural areas, it is still very, very primitive. If we grade it, now we have started grading, but it doesn't fit into any grade. So there is a primary care, secondary care and tertiary care ICUs that we all knows. But if you look at the services which is providing in the periphery, it is not of a level 1 also. The number of available beds is also disproportionately low. If you look at the population, with the population of India, the available bed is 80 to 90,000 as per the 2010 guidelines, so which is very, very low. And the doctors' density is even low. Forget about the trained doctors, the overall density of the doctors is even low. So these are the real critical care challenges that we are facing, and I feel that this Tele ICU is boon for this. For the periphery, if you think, just have a one case scenario that somebody of your relatives in the periphery is having a severe septic shock, and patient is on noradrenaline, adrenaline, he is not shiftable to the tertiary care, and the doctors who is available, he is not trained to treat this patient. What is the situation? Initially, we have started, I'm now telling you the real problems, as Shilpa Madam has told, that initially there is a problem with the net connections. So we have sorted out that we have taken the landline with the fibers inserted. Then there is a problem with the delaying. So the delaying solution, it took almost 6 to 7 months. We have visited so many places that how to reduce that delay. So there is a delay of 5, 6, 7 seconds, even with the Skype. So we have met so many people for this delay. So many software we have installed. Lastly, now we can say that our system has a 1 second delay, because in the critical care we cannot afford to have a delay of more than 5 seconds. If somebody is having a CPR and 5 seconds, then you will lose the patient. So these all problems we are facing. So from the remotely placed hospital, it comes to the Tele ICU center, and we can incorporate so many centers where all these problems are there, either the problem with the structure or problem with the trained staff. suppose this is a current some situation that the doctor says that he is confused what to do, whether to apply the option 1 or option 2. In that condition, what to do? He is really struggling, and even the relatives are more struggling that what to do. So he can ask the person who is sitting into the remote center, who is well trained, so he can guide that this is a treatment plan. So then at least he can tide over with the crisis. So it is a really boon for, I think, for all critically ill patients, that at least that time is saved, and time is life in critical care. So the another important thing is he can discuss with the experts at the remotely placed center, because as there are so many people, a group of intensives is there, so he can discuss that what to do in this condition. He can even take the help of the current updation, and he can suggest. So this is our own website, Tele ICU Care. It is supported by the web application. So you have all the details, hourly report, investigation, everything. So that really increase the treatment efficiency with this Tele ICU system. If you look at the advantages, it really reduces the mortality rate. There are so many data now. It reduces the length of hospitalization. It reduces the ventilator time. It increases the cost effectiveness and efficiency. So suppose this is ICU, you have a scarcity of the staff, as Dr. Jetwa has told. So this is our kiosk. This is Tele ICU Care kiosk. That is a mobile unit that we are keeping in the ICU. So that goes which patient is more critical, and then you can see everything. That has a PTZ camera, so you can see even the detail, the color of the secretion of the endotracheal tube. So that detail you can see. So this is all about the basic Tele ICU, and we mean that we can connect with the different center in the periphery. The mobile applications we have not keep open. We have kept only restricted to the ICU, so the sister can use everything. Sister is scanned. Suppose some consultant has taken the round, so she can scan it and put it into the applications, so that the all data will be uploaded into the central station, so I can visualize that. So this is a monitoring center intensivist. We have a 6 screen into our central. So where in one center we see the central monitoring. So the central monitoring which the remote center or a peripheral center has. So we can set all the alarms from here. So that is an added advantage. So suppose the person sitting into the peripheral ICU doesn't know what to observe, what to monitor, but we know that what to observe. So we can set the alarms from here, and we can have a pop-up alarm here. So we can identify emergency much more earlier than what he can identify. The another is a hospital information system, HIS. So whatever the data the patient has there, all the notes, clinical history, progress sheet, consultant notes, everything they scan and they can upload here. So I have virtually all files, all the data of the patient here. I can see at any time. The third is laboratory. So lab data. So we have tie up with the laboratory. So once they do the investigation, everything will be uploaded here by mail. So that is in the patient's file. Same thing for the radiology. We have a medico-legal data. We took a consent that our patient is observed by the Tele ICU consultants, and we don't have any problem. They are not responsible. So because now there is a Tele ICU law of India. We'll discuss it into the panel discussion. So that everything is available. So that all data will be uploaded into the patient's file. And one data is have audiovisual communication. Now the beauty of audiovisual communication is it has so many advantages. It is not only that you see the patients and you can talk with the consultants, or you can talk with the medical officer. You can talk with the relatives. So you can counsel the patients. You can train the staff. You can do a web conferencing. So there are more than many advantages of that. Now we go into the detail one by one. So this is our kiosk. From there you can see the patients, and the staff can talk with us. Now, as I told, what are the data that is needed? That is AV communication, continuous monitoring, lab data, radio data, IO chart, instruments data. Suppose now ventilator, they have direct attachments. Infusion pump, they have direct attachments. So you can see online that how much dopamine is going, how much NORAD is going. You can see the waveforms and loops, everything online. History and progress notes. You can ability to place notes from here, placing orders, medical legal data, and some others data that you can directly, suppose you have a leads there. You ask sister that put a 12 leads and you have a ECG here. So now the systems are advancing in that fashion. As I told you that the AV communication is very important aspects. So we have a PTZ camera, very high HD zoom lens camera, that you can see even the patient's respiratory excursion. So you can accept by having a physical touch, you can do all the things. So we have a solution for that. What we do, we train the staff for first 2 to 3 months into the basic ICU procedures. They can intubate the patient, they can put a central line. So if they know that what are the procedures that we have to do in the emergency, then everything else you can able to manage from the remote centers. Now challenges, as I told you that this is really a road less travel, and these are the challenges, the language barrier. So if you look, because in India there are so many languages from the region to region. કાઠિયાવાડમાં બી અલગ લેંગ્વેજ છે, ઉત્તર ગુજરાતમાં અલગ લેંગ્વેજ છે, સુરત બાજુ અલગ લેંગ્વેજ છે. So this is a real problem. So another thing, getting patients and family comfortable with this. So still this is new things. So they are still not able to understand. અરે સાહેબ એવું થોડું હોય, તમે જે કરો બરોબર, એમને ત્યાં ક્યાં જોવું પેશન્ટ. So they cannot understand. Delay in transmission of data, as I told you. The delay is still a big problem. I was discussing with the other centers. I think the third center in India. The Chennai and Bangalore they are doing. Hyderabad is an extension of Bangalore, and our is the third center in India. So they have this problem, the delaying in the transmission, and always have backup plans. So because having this backup plan, it become little costly. Monitoring as this is it looks simplified structure, but it is not. Because the challenge is, as I told you, is not all ICU are central monitor. In the periphery, this is a problem. They don't have central monitor, because suppose 6 monitor all are of different companies, because they are taken by the bargaining. So 2 are from China, 1 Philips old model. So this is a problem. So some have only single channel monitoring. So then what we do, we sometimes do RDS, sometimes do team viewer. So these are the problem. And to upgrade this, we have to convince them. We have to ask them for the extra cost, extra burden to them, which they don't like. So this is an teething issues. So that can cause a delay in data acquisition. So that is a problem. Lab data, I think it is very simplified. Nowadays everybody is using this. All the ICUs, they just the phlebotomist took a sample and then they will give data online. So you can take a printed sheet from here. So that is a problem. Same thing for the radiology data. Tele radiology is I think the most advanced structure if you look at the tele solution in India. Now this is our data sheet where the person is putting the data. So the data what we are getting from the lab or data what we are getting from the radio, so we are putting it in our own data. The advantage of putting data again is you can see the trend. Now in our software there is a system that you can see the trend. So if the rising creatinine, if there is a rising or falling down the hemoglobin, the rising WBC counts, you can see the trend. So by having this system, you can able to identify some problem very early. So that's why we keep one data inserter into the team. So his work is to put a data based in world for this Tele ICU, E-ICU. So they have the system that the staff is not doing a paperwork. Cleveland Clinic is paperless since last 2009. It's the first paperless ICU of US. So what they are doing, that they put everything into the tablet. She fills everything in the tablet. So all the systems come directly into these. We don't have. So what we are doing, we ask the staff. So that's why we have developed this mobile application. So it is very simplified. She just scan it, and the scan photo directly come into the central. So what she need to do, every hour she has to write it and she has to scan it. So then the person here, he has to fill it. So this is the extra burden, but then at least it serves the purpose at the moment. But yes, if you have a high graded system, then may be possible that everything comes online. So by having this system, at least you can see the trends. As I told you, the febrile illness, the blood pressure, everything you have a chart. So that we know that you can see by knowing the chart, at least you can able to identify certain critical disease early. Ventilator data, as I told you, in last 5 months, I think 5 to 6 months, the Messana unit is functioning very well. We have seen so many patients and we have saved so many patients. Some basic ventilator protocols, what we know, obviously the peripheral staff, they don't know. They just know the basics, that whenever the patient intubated, put on a ventilator with the same protocols, with the same modes and with the same data. Now we know that there is a disease specific ventilation, so we can tell them that put on this. We can see the waveforms, we can identify certain pathologies, certain complications quite early. So depends on that, we can ask them to modify the ventilator parameters. Patient's data and order entry. I think whenever you see the patients and when you order the something, it should be time specific, it should be name specific, and it should be consultant specific. So there is a standard SOP that whenever somebody is putting the knot, it has a time, because if you have seen patient at 7 o'clock, the potassium was 5, and you put a knot at the morning from 7 p.m. to 7 a.m., it will not make sense. Medically also. So time specific, it is directed to the consultants. So the medical officer will call the consultants that the Tele ICU consultant has advised that this patient has high potassium, so the calcium, soda bicarb, GI drip, blah blah blah, everything. So this already advised. So then their consultant asks, okay, do it. So now next thing that we are doing this all audio video recording, so that at least that recording will be saved in the server. So there has to be no conflict in the future. So as I told you that there are so many benefits of the Tele ICU. Still we are in a very primitive stage, but I feel that it is a good service to the society. Definitely, because the patient is monitored by the more expert and trained consultants. Crisis management, it is very important. You can guide the CPR from here because you are the much trained in CPR than the peripheral staff. Day-to-day consultation by the intensivist. Second opinion. So that also one of the advantage. Suppose in the periphery the patient with some immune disorder and the immunologist is not available, rheumatologist is not available, but at the remote center you have a rheumatologist. So you ask that please come to the center, to the remote place. He can come there and you see the patient and guide them. So that is possible. Even you can ask the cardiologist You can ask the nephrologist. So all the second opinion is possible through this. Staff training and web conference, as I told you, the staff training become very easy. Why I am telling easy? Because if you have a 5-6 center, so your time will be saved, and you can at the same time you can approach to 6 center. So it become very easy. You can review a latest delivery, review and deliver the latest informations. So the one person who is sitting into the cabin always serve something on the Google or on the up to date or whatever, and they can deliver the latest information. That this is the latest available, which is not possible when you are seeing the patients and when you are in front of the patients. So this is the backstage activity, but it is very, very important, and it is really cost effective. Believe me, it is really cost effective, because the patients has to travel to the tertiary care. If the patient can be managed at the secondary care, that is always safer. Additional benefits, as I told you, that you can implement protocols very easily, because you can observe that from the one center and you can implement the protocols there. You can ensure in the best practice. So all the bundles that you can in the critical care, that you can implement very effectively by means of Tele ICU. Because here one person has to sit here. Even in our ICU we take a morning evening rounds, but here one person is there only. So the observation, the supervision, the monitoring is little more effective than even conventional. It's a sense of security to patients, family and bedside staff, because they feel that somebody is observing us. There is a third eye which is observing us. And as I told you, that early recognition of the problems. There are so many datas. What Tele ICU cannot solve, as I told, that the procedures and emergencies you cannot do. Overconfidence is one problem, because they feel that somebody is there, so enjoy. And the initial cost of this setting up is little cost. The cost issue is real. There is a problem. So we are thinking in that fashion. So I've taken the references from these all journals. This is our company, Virtual Healthcare. This is our kiosk. This is our own kiosk. Yajat is third eye. So this is a kiosk. This is available at Mehsana. We have started one center in Mehsana, and we have installed another in Nadia this week. The second center will start. And thank you very much.